So our next disease condition is polyhydramnios. So what is polyhydramnios? See, in our uterus, we have amniotic fluid, amniotic cavity. The fluid inside this amniotic cavity is known as amniotic fluid. So if the amount of amniotic fluid is more than the normal, it is not called, it is called polyhydramnios, and when it is less than the normal, it is called oligohydramnios, right? So the polyhydramnios, when we talk about the polyhydramnios, if it exceeds more than 2000 ml, it is known as polyhydramnios, and the AFI will be 25. Okay. So what are the reasons for polyhydramnios? What are the causes of polyhydramnios? As I have already mentioned, at birth the baby might be having gastrointestinal tract or some central nervous system defect, because the baby won't be able to drink the amniotic fluid, so that it won't be regulating inside the amniotic fluid. So that is the main cause. The baby might be having any gastrointestinal tract, the GA tract abnormalities. That was the first cause. Second cause is maternal diabetes mellitus. Maternal diabetes mellitus. Then twin transfusion. Okay, so twin transfusion, in twin transfusion, a possible complication of identical twin pregnancies in which one twin receives too much blood and the other may receive too little. That is twin transfusion. Okay, so in the uterus there might be two babies. One may receive more blood, while the other may receive least amount of blood. Then blood incompetencies between mother and the baby. So that might be the another reason. Okay, blood incompetencies between the mother and the baby. Next and the last one is infection during the pregnancy. Infection during the pregnancy may also leads to this polyhydramnios. And what are the signs and symptoms? How you can say what the signs and symptoms may be? Any idea? So when the abdomen is huge enough, there will be shortness of breath. Okay. First one is there will be shortness of breath. Then swelling in the lower extremities as well as in the abdominal walls. There will be uterine discomfort, fetal malpositions. For example, mainly breech position. Okay, so those are the main signs and symptoms which is associated with polyhydramnios. There might be shortness of breath, then swelling in the lower extremities and abdominal walls. Uterine discomforts will be there, mainly contractions might be there, and fetal malpositions like breech presentations might be precipitated. Next is the complications. What are the main complications of polyhydramnios? The main complication of polyhydramnios is premature birth. Premature birth, pre-birth. Okay, premature birth. Then a premature rupture of membrane, PROM, premature rupture of membrane, PROM will be there. Then what? Abruptio placenta. Then there might be chance. There is a chance of abruptio placenta. Then umbilical cord prolapse. Cord prolapse. Umbilical cord prolapse. Then stillbirth. That is dead baby. Stillbirth. Then a larger amount of bleed, that is heavy bleeding. Heavy bleeding will be there. Heavy bleeding. So these are the complications of polyhydramnios. Then how will you diagnose it? How you can diagnose whether the patient is having polyhydramnios? The basic thing is the abdominal girth. Okay, so when we are diagnosing it, the first one is assessing the abdominal girth of the mother. So to give a correct and adequate result, we'll go for UST. A simple UST will guide you whether the mother is having any other abnormalities or if the mother is having polyhydramnios or not. Then what? What do you mean by AFI? I have once said the AFI. What is AFI? It is amniotic fluid index. Okay. In case of polyhydramnios, it will be more than 25, and in oligohydramnios, it is less than 5. Okay. So we'll do the blood test to check whether associated infections is with polyhydramnios or amniocentesis will be done, or non-stress test or the or the biophysical test can be done. So what is it? What? How will you treat it? See, actually, what is the underlying cause that you have to find out? For example, if the patient is having if the mother is having diabetes, you have to treat the diabetes. Then if in case of preterm baby, okay, if in case of preterm baby, if the polyhydramnios is very high, you have to drain the amniotic fluids. Okay, so there is a chance of, look, actually, when there is a when we are draining the excess amount of amniotic fluid, there is a chance of rupture of membrane. There may be preterm abortions will be there. Then placental abruptions can be taken place. Clear?
Mm.
Okay, and medicines like indomethacin. Okay, this indomethacin will help to reduce fetal urine production and amniotic fluid volume. Okay, please write it down. Please write down the medicine. Indomethacin will help to reduce the fetal urine output. Okay, and indomethacin is not recommended beyond 31st week of pregnancy. Okay, then what, in these conditions the baby might be having, or the mother also will be having gas reflexes, that is GERD, and nausea, vomiting. Okay, and if you have a mild to moderate polyhydramnios, you will be able to carry your baby to term. Okay, that is up to 28, sorry, up to 38, 39, or 40 weeks. If you have severe polyhydramnios, you have to discuss with the condition, and if the baby is healthy enough, if the baby have reached a stage of viability, we'll go for what labor. Okay, so that was about polyhydramnios. Clear? Next is oligohydramnios. So what is the level of oligohydramnios? It should not be less than 200, or you can say that if the amniotic fluid is less than 200 ml, it is oligohydramnios. Okay. So in polyhydramnios, it was 200, 2000, whereas in oligohydramnios, it is 200. When the amount is less than 200, you can say that oligohydramnios. Then what? What are the causes? What are the causes of oligohydramnios? So as
Increased absorption.
no, we said that in polyhydramnios, the baby will be having disorders with the GI system. So what about oligohydramnios? The baby will be having disorder with the urinary system, because the baby is drinking the same amniotic fluid, and um, the baby is urinating to that amniotic fluid. Okay, so that maintains or that regulates the amniotic circulation. Okay, what are the most common causes of oligohydramnios? First one is congenital effect, congenital abnormalities that affects the genitourinary tract, kidneys and the genitourinary tract. Then problems which is associated with the placenta. Problems associated with the placenta. Then hypertension, so preeclampsia. Hypertension, so preeclampsia. Or diabetes, dehydration also. So what are the signs and symptoms of amniotic fluid? The uterine size will be small, and the mother won't be able to feel the movements of the baby. So that is also in the polyhydramnios too. Okay, both in case of polyhydramnios as well as in the oligohydramnios, the movements of the baby cannot be easily what identified, because in the polyhydramnios, some other fluid, but the baby will be inside the huge amount of fluid, which will make it so difficult for the mother to understand if whether baby is kicking. The same condition happens in oligohydramnios also. If the baby is since there is no amniotic fluid adequate amniotic fluid inside the amniotic sac when the baby kicks, or that will not allow the baby to kick. So that is the third thing. Then weight, there is consistently decreased amount of weight gain. And what are the complications? As we have already said, preterm birth is a complication, stillbirth, then miscarriages and deformities due to compression of the womb. Okay. Then the complications, the main complications may include umbilical cord compression, fetal growth restriction, respiratory issues, then what? Infections also. So that was about oligohydramnios. Next is abnormalities of placenta. Abnormalities of placenta. Abnormalities of placenta. So the main first abnormality of placenta is placenta succinturator. Placenta succinturator. What is placenta succinturator? Shiny, what is placenta succinturator? See, if this is a placenta, okay, and the placenta is again having an extra lobe. So this condition is known as placenta succinturator. Okay, one small lobe of placenta may be placed at a varying distance from the main placenta. Okay, so suppose this is a placenta, the placenta may have a lobe which might be at a reasonable distance from the placenta. That is known as placenta succinturator. And what these condition may leads to? So the placenta succinturator may leads to PPH, postpartum hemorrhage. Then it may leads to primary or secondary hemorrhage, simple primary or secondary hemorrhage. Then subinvolution of the uterus. Okay, subinvolution of the uterus, uterine sepsis, polyps, etc. That was about placenta succinturator. Second condition is placenta extracoriolis. Placenta extracoriolis. This placenta extracoriolis. So this is why this placenta extracoriolis happens. That is due to smaller chorionic plate than the basal plate. Okay, that is due to the smaller chorionic plate than the basal plate. So this placenta extracoriolis is again divided into two types. Okay, that is circumvallate placenta, circumvallate placenta, and placenta marginata. Circumvallate placenta and placenta marginata. So what is the circumvallate placenta? Fetal surface is divided into central depressed zone surrounded by a thickened wall ring. That is placenta circumvallate placenta. So please go and check in the Google regarding these images of these conditions. So when you see it once, you will be able to remember it more often. So the circumvallate placenta is a condition where the fetal surface is divided into centrally depressed zone surrounded by thick wall ring. For example, this is your placenta, and if here the baby is attached, at that area you can see a depressed area. So that is known as circumvallate placenta. Second is placenta marginata. So thin fibrous ring is present at the margin. A thin fibrous ring is present at the margin. Thin fibrous ring is present at the margin. That is known as placenta marginata. Next, the third one is placental membrane. So, as you know, the placental membranes are having and two conditions: long placenta membrane and short placenta membrane. Okay, so placenta membrane is here. It is having two types. First one is long placenta and second one is thin placenta. Okay, next condition is cord abnormalities. Cord abnormalities. So first cord abnormality. First cord abnormality is battledore placenta. Battledore placenta. Battledore placenta. Here the cord is attached to the margin of placenta. Okay, cord is attached to the margin of placenta. Suppose in the uterus, your this is your margin and placenta. That when the cord is attached to the base of the, see, suppose the cord is attached to the margin, it is known as battledore placenta. Second condition is velamentous placenta. Velamentous placenta. So the cord attached to the margin of the placenta, which is known as battledore placenta. And what is in velamentous placenta? Cord attached to the membranes. Here it is attached to the margin of the placenta, whereas the velamental it is attached to the membrane. Okay, what is vasa previa? What is vasa previa? So vasa previa is nothing but blood vessels transfers through the membranes owing the internal ocean. Okay, for example, vasa previa means the this is the what presenting part, right? So the presentation. So at this area, the blood vessels can be seen, blood vessels and the membranes can be seen overlapping. This is known as vasa previa. What is the length of the cord? So a short cord, a short cord means it is less than 40. Sorry, it is less than 20 centimeters. It is less than 20 centimeters. This one is less than 20 centimeter. Okay, first one, that is short cord. Second one is long cord. In short cord, it should be less than 20 centimeters, whereas in the long cord, it is greater than 50 centimeters. So we can actually see the normal length of a cord is 50 centimeter. Okay, so if a short cord is less than 20 centimeter, where a long cord is more than 100 centimeters. Okay, and the long cord, it is again divided into true knot and false knot. So in true knots, water stelly prevents the tie of the vessels. Okay, and in the false knot, due to the accumulation of water stelly, for example, see when this enters through here and it comes out. So this is known as true knots. You know what node is knot is, right? This is true knot. What happens in false knot? See, due to the presence of the water stelly, it may feel like the code is having a knot, that is known as what false knot. So only this much is enough, because um, there is nothing much to do with the treatment modalities. Just when the baby is out, we'll cut the code. So next is the hypertensive disorders in the pregnancy. Hypertensive disorders in the pregnancy. So in the hypertensive disorders, first one is preeclampsia. So preeclampsia is nothing but multi-system disorders of unknown etiology. We don't know why, what is the reason. It affects the multiple system, and it is characterized by development of hypertension to the extent of 140/90 or more with proteinuria after 20 weeks in a previously in the previously when if the mother was normal. Okay, that is preeclampsia. There is a high chance of developing BP more than 140/90, and it's a multi-system disorder too. So that was preeclampsia. So you may get how to differentiate between all the other conditions. Next is this pregnancy-induced hypertension. So in pregnancy-induced hypertension, it may develop it essay directly on the gravid state, that is known as gestational diabetes mellitus eclampsia. On it may lead, sorry, pre-eclampsia, and it may leads to eclampsia. Classification of eclampsia. Okay. It is divided into primary. It is classified into primary and secondary. So primary means that is pre-eclampsia, and second one is eclampsia with convulsion. Eclampsia with convulsion. And in the second degree, this is primary degree, and in the second degree, it is pre-eclampsia, eclampsia superimposed on hypertension. Okay, that is pre-eclampsia, eclampsia. Both the conditions affecting the person or the mother. Eclampsia and pre-eclampsia is super associated or superimposed on hypertension with chronic renal failure. Okay, so that is second classification. So how will you diagnose the BP? It's nothing but mean arterial pressure. How will you diagnose mean arterial pressure? Systolic pressure plus 2 diastolic pressure. It's nothing but systolic pressure plus 2 diastolic pressure divided by 3. Okay, so when a baby, when a person is having what, for example, 170 bar, 170 bar, 30 mm, is it normal? No, we won't say it is normal. So why the systolic as well as the diastolic pressure, when selected and cut, the hello,
Hello.
are you there? Okay, fine, fine. So so when we take this and selected and cut it, so it won't be within the mean arterial pressure value. So the mean arterial pressure value is be around 180 to 120. Okay, it should not fall more than 60, or it should not rise more than 140. Okay, this is the mean arterial pressure value. And one thing I have to say here is that when the mean arterial pressure is more than 105, or when it raises in 20 mm of HD, which is significant. So in mothers of preeclampsia, there will be edema. Okay, so this is the I am talking on the basis of prometric exam. Okay, there will be edema, and there will be a pitching over the edema after 12 hours of bed rest. Even after 12 hours of bed rest, there will be pitching edema, and there will be rapid weight gain. There will be rapid weight gain, and there shall also be proteinuria. So there you can see protein in the urine. Proteinuria will be there. So how it can be assessed? It can be assessed by dipstick method. Dipstick method. You can assess it by dipstick method. Okay, so this one is important. What is HELP syndrome? HELLP. What is HELP syndrome? Hemolysis. Okay, liver enzymes, low protein. Is it low protein? No, it is liver, low platelets. Okay. Hemolysis, elevated elevated liver enzyme, and low proteins. That is known as HELP syndrome. So, as signs and manifestation symptoms, there might be mild and angle swelling will be there. The alarming sign of preeclampsia is that it is associated with headache and disturb in the there will be a disturb in the sleep, decreased urine output, epigastric pain will be there, and eye symptoms like blurriness of eyes, as well as what diminishing the vision. And how you can diagnose it? So the serum uric acid will help with that. When the serum uric acid will be more, and also it can be precipitated with, excuse me, variation in the electrolytes as well as in the RFT values. So the treatment is nothing but sedation. We will get sedative, diuretic therapy, antihypertensive therapies. So labetalol is a priest right on all these conditions. Okay, in hypertensive crisis, in hypertensive preeclamptic crisis, labetalol is the drug of choice. 200 mg in NS over 20 mg per hour. That is the group. That is the dose and hydrazolide will be given, and finally we may go for nitroglycerins on the NTGs or nitroprusides. So that was about preeclampsia. So when talking about eclampsia, which was from the Greek word like a flash of lightning, that is the meaning of that term. Preeclampsia, when complicated with, okay, so how the eclampsia is affecting? Preeclampsia complicated with convulsions and edema in eclamptic condition, that is known as, or which may be complicated to complicate the condition, or the preeclampsia when complicated with convulsion and coma, which may leads to, or which is known as eclampsia. Okay, so eclampsia is nothing
Okay.
but a condition which increases the pre-eclamptic stage, or which complicates the pre-eclamptic state with convulsion or coma. Okay, that is eclampsia. And what are the clinical manifestations? It's nothing but fits. There are four stages in the fits, or four stages of this convulsions in eclampsia. First one is premonitory stage, second one is tonic stage, third is clonic stage, and fourth one is status epilepticus. Okay, so the premonitory stage, what happens in the premonitory stage? There will be Shiny, this is important. Okay, you may get questions from eclampsia,
Mm.
preeclampsia. So the premonitory stages, there will be unconscious will be the twitching of the muscles, faces, tongues, limbs, eyeball or eyeball rolling will be the in these may be for more than not more than 30 seconds. Okay. Next is the tonic stage. So in tonic stage, the tonicity goes into spasm. Trunk will be in the oppositotonous position. Hands will be flexed. Limbs also will be flexed. Thought sorry, then so thought may be interfered because of the patient is unconscious. Tongue may be protruded. Cyanosis will be there, so that might be for 30 seconds. Okay, next clonic seizures or clonic condition. So all voluntary muscles undergo alternating contractions and relaxations. So tongue biting will be the, okay, this clonic condition may stands from 1 minute to 4 minutes. Then comes the status epilepticus. Okay. So what are the differential diagnosis? So differential diagnosis of preeclampsia might be epilepsy, then hysteria, encephalitis, meningitis, etc. Even cerebral malaria and poisoning are also differential diagnosis. And what are the complications? Here there will be something related with the respiratory tract also. So ARDS will be the, emboli will be the, then what? Renal failure, cerebral hemorrhages, retinal detachment will be the thrombocytopenia and DIC. So those were the complications. So treatment will go with magnesium sulfate. Why magnesium sulfate? It will block the neuron calcium channel influxes, and it also decreases the acetylcholine sensitivity. Then we'll go for the status epilepticus. We'll go for thiophanton sodium. Okay. Next condition is what? Antepartum hemorrhage. So that's also important in here. So antepartum hemorrhage with bleeding from 28th week to the birth of the baby. So the first antepartum hemorrhage condition is placenta previa. So you know what is placenta previa, right? So the placenta previa is nothing but low-lying placenta. So there are four stages of placenta. For example, this is your internal os. If partially covering the internal os, it's one. When the placenta previa is covering the one half, or 1/2 of the uh, internal os, then it's a second stage. Then it is second stage. When it covers the 3/4 of the portion, and it is third stage. When it completely covers the internal os, then it is fourth stage. Then the fourth stage. Okay, so what are the causes of placenta? So we have said the drooping down theory. Okay, when the zona pellucida covering is not, or the zona pellucida covering is intact, it may come down and may settle in any part of the lower portion of the what lower portion of the uterus. Then from there it started to disintegrate into the what we muscles of the uterus, and it may start from growing from the. So that is known as, that is a cause of the dropping down theory. Then what? Persistence of chorionic activity. So when the chorionic activity is persistently active, then or decidual defectiveness. Then when there is the big survey, the conditions like that. So next is what of the placenta. So and one more thing, placental migration. There might be placenta migrate. There is a chance of placenta traveling from one area to another. That is known as placental migration. It's nothing but there might be some change in the position of the placenta. That is known as a placental migration. And the clinical manifestations of placenta. Here we have to focus on the clinical manifestation of placenta previa is there is a sudden onset painless vaginal delivery, and the head won't be fixed, there will be floating of the head. Okay, so that is a main clinical symptom, sudden onset of vaginal bleeding which is painless. Okay, so let us, for an exam point of view, we shall convert this into two categories: the bleeding in the placenta previa and bleeding in the abruptio placenta. So you know, in both conditions the bleeding will be there. So what is the nature of the bleeding? In this condition, the placenta previa, it is painless. Okay, and it is also there, it is causeless, no cause will be there. But in abruptio placenta, the bleeding is painful. Why? Because it is concealed, and this it may leads to the condition which poses the bleeding might be a trauma. Okay, so I had said this when this is the uterus in abruptio placenta, concealed abruptio placenta, the bleeding might be started from here, and there is a pooling of blood inside the uterus itself. Okay, this is concealed abruptio placenta. Then here in placenta previa, there will be revealing of the blood. You can see the blood in the placenta previa, whereas in the antipart, in abruptio placenta, the bleeding might be concealed. See, like this, like this. It's a concealed labor or concealed what? Concealed abruptio placenta. So here placenta previa might be bright red because it's it's a fresh bleed. Okay, whereas abruptio placenta, it is dark red. Dark red. And malposition. What about the malposition? Malposition. Malposition will be good. Malpresentation. Malpresentation will be the okay in placenta previa, but not in abruptio placenta. In the FHS, FHS will be present in placenta previa, where in the FHS form heart rate will be absent or concealed in this what abruptio placenta. And what are the complications? What are the complications of this condition? So the some nothing but APH, antepartum hemorrhage will be there. Then malpresentation, preterm labor, premature rupture of membrane, cord prolapse, dilation will be so low. Okay, uterine atonicity, retained placenta. Retained placenta means some portion of the placenta might be retained in the uterus. That is retained placenta. So in the abruptio placenta, we have already seen that it is again divided into concealed, revealed, and mixed. What are the causes of abruptio placenta? Hypertension, trauma, short cord, or a sick placenta when the placenta is sick or cord is very short. Folic acid deficiency like megaloblastic anemia. Okay, torsions, cocaine use, etc. So how will you diagnose it? Hemorrhage, shock, or coagulation disorder. We'll diagnose on the prognosis, like if the I'm talking about the prognosis, how the shock might happen, or what is the status of the hemorrhage or coagulation disorders, etc. And also ischemic pituitary necrosis, that is failure of lactation. And me failure of Sheehan syndrome. Okay, that is not Sheehan syndrome. Sheehan
Ischemic.
Sheehan syndrome, failure of lactation. Sheehan syndrome, failure of lactation. Okay. And there are other conditions like premature rupture of membrane. See, in our exam, they'll ask, what will you do when there is a premature rupture of membrane? So you have to just identify the condition and what as soon as you'll do. Okay, same in the condition like post-term pregnancies, 20 week beyond. When the baby is 20 week, baby is having 22nd weeks beyond, the main complication is meconium aspiration. Okay, so then next is cephalopelvic disproportion. It's nothing but what directly in relationship between plant and that is the head and the pelvis. Okay, the the cephalopelvic disproportion CPD, the head and the pelvis, the head and the pelvis. Okay, there might be what problem with the head and the pelvis, that is cephalopelvic disproportion. Then abnormal uterine actions. We don't want those. Hypotonic activity, constriction ring, or cervical dystocia. I don't think not. I don't think those questions might be happen. They might ask for that. So in the next session, we'll complete the what gynecology. Okay. So the remaining portion is exchange transfusion, complications, that is mainly postpartum hemorrhage PPH, and therapeutics in obstetrics. That's the main medicines. So we'll stop here.